COVID regarding the management or the protocols or otherwise quarantines, testing strategies, discharge policies. So everything is going on changing. It depends upon the situation. So that's why the training sessions are very, very important when there are a lot of doubts for you. So many times you are calling us regarding these protocols or otherwise guidelines. So we try to change how the government gives the guidelines. So appropriate way. So we are trying, but there is definitely there is a chances of getting confusion for you at the ground level. Definitely it will be there. But as a total protocol, so we will prepare with a large view only, but small things maybe come in between. For that, so we have to decide at that level. So with this introduction, so I want to make sure that there are more than 180 plus logins are coming. So everybody is coming. It seems working day it is today, and there are so many people are in wards or the rounds. So people are welcoming. So in the meanwhile, so I want to update the what is the COVID and epidemiology, and also regarding of the protocols of little bit about the treatment protocols. Next, please. Yeah, next, please. Nagendra. Nagendra, next slide, please. Yeah. So there is a current situation is it's going on every day, day by day. It is increasing, and you can see that backslide if you go. So all over the globe, so everybody is aware that all the newspapers, so you are getting all these things and TV. So this is nearly more than 1.9. It is crossed. It is day before one. It's still. So there are almost death is also going on increasing more than 5,000 already. It is crossing. So at this time, so we have to hope that the suppressive stage of the lockdown is gone. Now the stage of the mitigation stage is already started. So we have to face this. So at any day, so we have to face this one. There is no other way. All other countries also did the same thing. So we are also doing, but we have to see that less damage should occur towards the elders. So what we are discussing today topic is on pregnant and children. So everybody. So this is very important one. So to acquire the herd immunity, so we have to go through the everybody has to go out, but with more precautions we have to take care, because it's such a huge population of the 1.3. So 130 millions of the population to get the herd immunity, it's nearly 60 to 70% of the people have to infected. But if the 70 crores of the people are infected, that means that if we take the 2 to 3% of the mortality is also very huge number will be there. So that's why everybody should be careful that don't instead of the we are so immune, we are not going to affect with this virus, because we are seeing that there are already 62 deaths already happened in Andhra Pradesh. There is a 36 years old girl, lady is also there from that onwards. So 45, 41, 50 to 60 is more age group is there. So that's why be careful that don't underestimate the virus, don't overestimate your immunity, so that we have the lot of problematic for you. So this is what the total deaths and all those things. So next slide, please. Nagendra, next. So this is our Andhra Pradesh picture. So you know that all the testing strategies of this one, and this is the total confirmed cases more than 3,000 and 62 deaths. And most important one is we are discharged more than 2,135 cases. So that's one of the good news for us. So another most important our testing strategy, if you see that we are almost near to the 4 lakhs, so we are moving, it's more than 3 lakhs 72,000 yesterday's only. And today we are doing another 10,000. So probably it comes as a 3 lakhs 82,000 today's results. So within 3 days, so we'll cross the 4 lakhs tests. So it is India's topest number one. And then when the testing strategy comes, so I'll go. Nagendra, can you shift to the my PPT? Yeah, not this one. This one is Anil's. So go to the my. Yeah. So this is one of the most important ones. So we have to remember that don't panic. So you know that what's about this or not. So you are seeing this one is that seasonal influenza. If you take this one, so this is 1 to 2 is there. And if you take the SARS, it is 3 to 5. And if you take the measles, it is more than 12 to 18. So, but whereas COVID is, we are lucky that it is 2 to 3. And we are kept in that one less than 2. Once it comes to the after this mitigation stage, it is less than 1. Then only that is we are immune and the disease case fatality rate is become less. So that's why we are choosing this mitigation stage to get the herd immunity and to get the or not is that spreading rate from 1% to less than 1% when comes, then only the case fatality will become less. So all the governments are planning or not towards the less than 1 is very, very important one. Next, please. Next, please. Yeah, Nagendra.
Yeah, sir, there would be a lag. If I am changing the slides, it takes.
Yeah. Anything? Slide is not moving.
Yes, doctor, I believe Dr. Nagendra is having some difficulty in actually accessing the slides.
Okay, right. So then coming into the okay, in between slides. So let us check that one. Next most important one is that so I have to explain to you regarding this one is that so in India, so what is about this COVID pregnancy related? So there are 34 births per minute in India and 2062 births per hour and nearly 50,000 births per day and 1.5 million births per month. And we are expecting from March to 11th to December 16th, there are 20.1 million births in India this period of this 9 months. So we have to be very, very careful regarding this 20.1 million deliveries will occur. So out of that, how many becomes positive and what could be the probable things will occur to those maternity or the fetal, those things are very important one. And then coming into the most important of the testing strategies, so you should understand that we are doing the RT-PCR method. Everybody knows that this testing strategy is very, very important one. You have to know that RT-PCR throat swab you have to take, and it will take at least more than 6 to 8 hours to get the results for one batch. And if you go through the 3 shifts also, you know that microbiology, you are also working in the medical colleges, the manpower and all those things. How much manpower, if you know, you can go on increasing, but there is a definite scientist who should be needed, and the microbiologists who are experienced are needed. Those we cannot procure more than whatever the people are available. So all over the state they are dispersed, and we are having the more than 14 RT-PCR centers. So once we are having this migrating people and everybody is coming, So there is a lot of time is delay for coming up these reports, because one lab is having the capacity can go up to the hardly 140 or the 150, or otherwise there is even some shifts that they can do for the some machines, or the Swims is having 2 machines, Vijayawada 2 machines, 3 machines like that. So they are doing the more than 250 to 300 tests also per shift. So they are trying, because one process of extraction is going on, one process of testing is also going on. But in spite of that also, with the RT-PCR machines, so we are able to do for the only 2000 to 2500 tests only. To get rid of this one, so we plan for that true not tests are we are doing. These true not tests, as you know that the CB-NAT or the true not test, which can come as two tests only will become the, you can do for at a time. So that will as a 1.5 hours, it will take time. So if you have the 10 machines mean that, so 10 into 20 tests only, so we are able to do for the 12 to 14 hours only. So please remember that one. There is a lot of complaints from your side that delivery for the mother is waiting and we are not getting the reports. And the true not is also coming for the one day it takes times, or second day it is comes. So this is practical problems are there for us. These are the practicalities that true not is also turned to be the late, because in quarantine centers or also the pre-operative surgeries or otherwise the deliveries where you are planning, or the SARI cases, ARDS. So where you are seeing all these things, so you need to go for the true not, because of it will come as a little bit fast. But whereas if everybody is sending for the true not, then it turns to be the little bit so late. That's also the another problem with this. And for this to get rid of this problem, so we try to go for the pooling methods. So RT-PCR only pooling methods from the green zone areas where the case fatality rate is less is there. Those areas, so we are planned for the pooling methods. So as you know that it's a 5 tests will be in the one tube. If one comes as a negative, so all are negative. If one comes as a positive, so we are doing that one. So that way is also some way you are planning for that. And then last is that CLIA machines also using for the 5 centers. So we are using, so that is Vijayawada and Gunturu, Ongolu, Nelluru, Karnoolu. These areas where the CLIA machines also were kept there to get the IgG, IgM positive. When there is no test is coming and you are hurried to get the delivery of the patient, when the CLIA, so you will get the within 3 hours. Some people are opting that, seeing that if the IgM positive or not. So that way also we are planning, but actually truly speaking, so testing strategy means that it has to be confirmed with the RT-PCR only, whatever the case may be. And but now with the new recent guidelines with the ICM are saying that it's a true not with the true not 1 and the true not 2. That is the stage 1 and the stage 2. So this stage 1 is true not presumptive, and stage 2 kits also supplied to the so many centers. If it is available, if you do that one, stage 2 kit is equal to the positive, means that it's a positive. So if you go for the stage 2 kit, there you will get that positive. That is positive only. So no need to go for the RT-PCR. So I think that is a testing strategy for the delivery. Any antenatal case is there, if the list is there, so you should call them at least 5 days before only you are supposed to do the test. Be ready with that case and try to plan for that in something good way that you can plan, because of when that hurry period. So if the patient comes and you are unable to do any testing strategy, and how many people are exposed, you don't know, there is a lot of problems are there. So I think that this one is that important one. So you know that say SARS corona is a beta virus, how with the droplet infections it enters into the lungs, and ACE2 is the centers where the receptors will affected over that one. And once this is affected, there is a macrophages, dendrite cells, and the epithelial cells. So all are getting multiplied, and the replication will be there total. And after that one, there is a decreased cellular immunity, and the humoral immunity will come down. So this is the consequences of this one. Once the immunity will come down. Next, please, Nagendra. So once this come down, So there is a chances of getting of the inflammatory markers are going on increasing. That is a major danger with this COVID is that everybody is reading about that one cytokine storm. So we are telling about this one. Next slide, please, Nagendra. So this cytokine storm, there is a release of this ferritin, so is going on, hyperferritemia will be there. And this is once this occurs is the lungs, so everybody sees that what is happening in the CE2, and there is a lung over this one, and there is alveolar expansion. So this is where all the effects over this one. For example, if the hypothalamus brain is affected, there is a hyperpyrexia will be there, hyperalgesia will be there, total pains and body aches will be there, and there is a release of all these interleukin 6 is we are also planning for that one, interleukin 6 inhibitors and tumor necrosis factors and serum ferritin and most important one is that C-reactive proteins. All these things are once there is a rising is there, so there is a cytokine inflammation will be there. Next slide, please. So once this is cytokines and inflammation is going on increasing, there is a lot of problem for us. And as you know, that is pregnancy is a hypercoagulable state itself. So next slide, please. So hypercoagulable state is also one of the dangerous one, where we are anticipating that thrombosis is also another most important cause of death in the COVID. So here that thrombosis and all other complications are very much common with the pregnancy. So we have to be prepared and ready with that diagnosis of this one. So that's why in our guidelines, so we are already given that any comorbid case is there or otherwise anticipating problems are there. So go for the C-reactive protein, D dimer, and the serum ferritin levels are very, very important one. If possible available is there, interleukin 6 is one of the most important one. So we have to go through that one and see that what is happening to the patient if any problems are coming. Next slide, please. So that is the thing. So, and you should know that, so what is the response of the disease? As everybody knows that it's a mild, moderate, severe, and the critical stages are there. So 80% of the patients will get rid with the, just with the mild or asymptomatic only. So this what I mean to show you that one, you please see this one. There is a clotting is very much already I told that, and patient gone into the hypotensive and ARDS and the lung injury is there, and there is a cell death will occur, and there is a decreased total immunity will be there. So these are the most important one that landed into the multi-organ failure, sepsis, and the shock, and patients are dying. So within no time. So this you should anticipate with the tests only, and you should try to see that D dimer, so how much it is increasing, ferritinous or levels are increasing, or at least for the CRP. If the child is there, most importantly, you can go for the lymphocytosis. Also for the lymphopenia to the lymphocytosis is also the indication that there is a some storm is occurring. So that way also, so you can see with the simple CBP also, so you can analyze that there is a possibility of this one. So based on this LDH is there, if the LDH is also available in all our hospitals, so where you can see that anything LDH is increasing with the proteins, which the where the liver is the storage of this one, there is an injury will be there. So these are all the some things, so you can try to get it and go for the little bit more careful treatment for these cases. Next, please. And if the mild, moderate, severe cases are there, so then you have to see that what is the time period is there, and according to the time period, so what is the recovery period. So these things are very important one. So this is the viral response phase is this is the stage 1 is the early infection, stage 2 is the pulmonary phase is the 2A 2B, so without hypoxia, with hypoxia, and stage 3 is the hyperinflammation phase. So these are all the very important phases with the mild, moderate, severe things so will occur. So if you take that viral response phase, so once comes this one is that mild stage will be there, early infection, patient may be asymptomatic and sometimes with just a little bit fever or anything. Here the problem with go for the management protocols for this one. So we are using the asymptomatic or the mild phases just with the vitamin C or the zinc or otherwise the antipyretics. That's also we are managing with that only. Probably we are thinking that zinc or the C is immunomodulators, which give that there is any chances of viral infection will comes less. That's only the aim. So once you coming into the stage 2 is that category 2A, 2B is there. That is nothing but is the pulmonary phase without hypoxia, with hypoxia. So previously we used to give the hydroxychloroquine when the pregnant is there chloroquine, but there is a lot of effects out there. The chloroquine is also there, but as you are the gynecologist, you know that you are usually frequently used to the write the chloroquine to the all the pregnant women. So there is no side effects with that chloroquine. So if you feel that, so you can go for the chloroquine, but don't mix up with azithromycin. So previously we used to mix up with the azithromycin, but we are not using this one. And with a lot of studies with this one, so hydroxychloroquine is WHO says that so you should supposed to stop the hydroxychloroquine, but whereas ICMR still now has not given any guidelines regarding of the hydroxychloroquine. There is a lot of controversy going on regarding this hydroxychloroquine. And once you are coming into the stage 3 is that very dangerous, and then 4 is that critical phase. Once the hyperinflammation phase comes, so there is a cytokine storm will be released. And as you know, that is the hypercoagulability state of the pregnancy is very dangerous to the pregnant woman. So that's why be careful. So whenever you are thinking that some possibility of any hypoxia is coming, or otherwise respiratory rate is increasing, any hyperpyrexia is there, so immediately so plan to go for the stay test and treat the patients so accordingly. So next slide please. So these are the some most important things, so we have to remember along with the what the delivery so you are doing. As you know that, so we have to take care of the first list of the patients. So what is that month anticipated expected date of delivery of those patients, and plan for the at least 5 days before or the 1 week before, try to ask them to come and do the tests, at least TrueNut or the RT-PCR, whichever is available, if the CLIA is available with you, or the rapid antibody test. So whatever it may be, so first you have to protect yourself, and also to see that whether the patient is positive or negative. Those things are very important one. But officially with the ICMR guidelines, so Government of India has given that you have to do the TrueNut. If the TrueNut 2 is with you, then plan for that. Otherwise, you have to confirm with the RT-PCR only. I repeat again that RT-PCR is only the diagnostic test still now. So other things are so have to only correlate only. So there is nothing like that. So replacement of the RT-PCR is not there till now. So for the time benefit and to say that negative, so we are doing that one, those tests. But for that positives to say that, so it's a RT-PCR till now is the gold standard. That's only the from the ICMR, that is only the one test. So with that only you are supposed to say that COVID positive. So I think that with this, so I'm concluding this little bit COVID update and protocols and the testing strategy and management protocols of this virus. So how it acts. And I think now the second speaker, Dr. Srilata, she's from Kurnool Medical College. I think she is the additional professor, associate professor of gynecology. And they did the successful 3 deliveries with the COVID positive patients. So that's why we approached to Dr. Srilata to tell her practical points. So what they face and how they did, and what is the clinical protocols they applied, and what are the outcomes. So may I now invite Dr. Srilata from Kurnool Medical College. Yeah, Srilata, are you here? Are you able to hear? Dr. Srilata?
Fine, sir.
Yeah. Are you able to hear?
Yes, sir.
Yeah. Please go ahead. You can share the screen share also. Yeah.
Everybody, this is Dr. Chileta. assistant professor, OBG.
Little bit voice, so you can go for little bit more voice.
I'm assistant
Volume.
professor, OBG, Kannur Medical College, Kannur.
Yeah. Yes, slide share you can go.
Topic for today is COVID-19 and pregnancy. At the outset, let me share experience in our institute for the past 1 month. As you all know, Kannur is red zone area, and GH Kannur has been declared as a state COVID hospital in April 24. Since that time, we conducted totally 890 deliveries. Of these cases, 3 were confirmed cases of COVID-19 with RT-PCR. Out of these 3 cases, 2 had normal vaginal delivery. 1 case required emergency LSCS for CPD. All 3 babies turned out to be negative upon testing 1 week after birth. There was no maternal morbidity or mortality among these 3 cases. Most important point to note here is that none of the cases was symptomatic. All 3 had no symptoms of COVID but diagnosed incidentally upon screening. How could we manage diagnosing those who had no symptoms? Let us see what changes that took place with the onset of pandemic. We all know COVID-19 spreads by close contact from person to person, droplet infection or fomites. That's why patients having symptoms of COVID, that is fever, cough and cold, had to go directly to respiratory OP. They didn't come to obstetric OPD. They had to go to respiratory clinic only. Only those patients having no respiratory complaints are allowed to come to regular antenatal OP. You can see the arrow mark showing non-respiratory OPD in the OP area. The OPD is located in the MCH building of hospital, which stands triage area also for those who come in labor. After reaching triage in this area, those who are confirmed to non-COVID stay here only. Those who turn positive for COVID are shifted to other block called COVID block. It's originally super specialty block of the GGS hospital. So once the lockdown is imposed upon us, how did it influence the antenatal care and the setup? To reduce transmission, we had to cut down the number of cases coming to antenatal OP. Only those patients nearing term pregnancy from 34 weeks onwards and those who had complaints early gestation also were allowed to come to OPD. By decreasing OPD patients coming to OPD, we could cut down attendance also. So we could maintain social distance in the OPD. You can see there is no mob in the registration counter of OPD. Patients are maintaining distance in the waiting area also. A routine checkup and advice. In addition to this, we gave advice about the hand hygiene, wearing a mask while they come out for checkup, maintaining social distance, staying at home always, and avoiding all kinds of travel. Dietary advice. They are advised to get high protein diet and iron-rich diet. Some had concerns over consumption of egg and chicken, as they know this is a zoonotic disease. We reassured them that it is not the case in the case of COVID infections. Those that turn to be low risk upon examination, we advise them home monitoring later on, unlike calling them every week and in routine cases in period of corona crisis. They are advised to maintain DSM chart at home, BP monitoring and bed record weekly at home itself. And they are advised to come back when they enter the last week of pregnancy or when they go into labor.
Dr. Srilata, I'm sorry to interrupt you. You can go for the little bit louder. So I'm getting the chat boxes, so they are unable to hear.
Shall I repeat the previous slides also?
Yeah, little bit louder.
Okay,
Or otherwise, go for the little bit, increase the value.
those who are high risk upon examination, though they're remote from term, like medical disorders, complicated pregnancy, they're asked to come for frequent checkups as usual. And at the same time, we impress upon the need for precaution measures while preventing acquiring infection. Which patient was screened for COVID-19 in an hospital? We screen all cases who come in labor. Though not in labor, those require admission, like high risk factors like anemia, hypertension, medical disorders complicated pregnancies, and all those nearing ED. They're screened for COVID, though they had no symptoms. Why do we test them? To provide appropriate obstetric and neonatal care, to institute infection prevention control measures, and for rational use of PPE by healthcare facility. So those require testing are patients in labor, though not in labor require admission like hypertension, anemia, and those needing ED. They are led to triage area from the regular OPD. In triage area also, they maintain distance and putting on a surgical mask. You can see medical officer who takes samples for testing is wearing level 1 PPE. Some patients come to triage area directly in labor. So they're examined here in the examination room and sampled for COVID here itself. The medical officer in the triage area who examines patients is putting on N95 mask and glove and no other PPE. Test performed here is TruNAT test. It's antigen PET test, highly sensitive, around 100% sensitive, and time taken for reporting is 1.5 hours. In the waiting period, the patient moves from triage area to waiting room here itself. You can see widely spaced cots in waiting room. Less number of patients attendance, and patients are kept on table to avoid fomites. Once the report arrives as negative, what do we do with them? They are moved to clean labor room from waiting area. Please note significant difference between the triage area and the clean labor room. Once in clean labor room, there is no need to use PPE. Observe the healthcare worker and patient wearing N95 mask and maintaining social distance. Suppose patient in waiting area needs emergency obstetric care before report arrives. We did not delay treatment because patient is in emergency. They treated as asymptomatic suspects because we come from the containment area. They treated as COVID positive only and suspects. So after reports obtained as COVID positive or negative, they are designated as either negative or positive after delivery based on TruNAT result. Other scenarios where testing is done postpartum are patient delivers in ambulance on her way to hospital, or patient delivers as soon as she enters triage area. So I have delivery in triage area for delivery of such cases also. Based on TruNAT report, we have 3 categories of patients. One is COVID negative, one is positive, other is suspect because she is waiting for report. Positive cases are confirmed by RT-PCR later on. In emergency conditions, both is TruNAT positive and suspects are treated as positive case only if they're in labor and shifted to COVID block of GGH Kannur by ambulance. During transport, the patient is provided N95 mask, attendant is provided N95 mask, and ambulance driver is given surgical mask, and all provided glove. After each transport, ambulance is disinfected properly with hypochlorite solution. In COVID block, we have a separate ward for obstetric patients. We have a dedicated team of healthcare workers with minimum staffing wearing L1 PPE to receive patient of COVID case. If patient is in labor, the delivery is conducted in urology OT. If patient requires cesarean section, it's done in NSOT. We use level 2 PPE for deliveries, level 3 PPE for cesarean sections. In postpartum period also, patient is made to wear N95 mask and the medical officer is wearing level 1 PPE. They are educated about hand hygiene and respiratory hygiene while feeding baby and about social distancing also after feeding. You can see patient wearing face mask over the N95 mask. We train health sanitary workers also in proper treatment and disposal of biomedical waste. What do we do with patients who are positive but not in labor? Guidelines say wait till test becomes negative. But one of our patients went in spontaneous labor and delivered for vaginal delivery. One patient who went into labor required section for CPD. So this is just a beginning. We are in containment zone. We should be prepared for the future. What do you expect in future after lifting of lockdown? We have to handle non-COVID cases, COVID cases, and most importantly, safeguard our pregnant healthcare workers. Let us see how we handle non-COVID and healthcare workers before going to COVID patients. So aim of management in non-COVID cases is to prevent acquiring infection. How do we do that? By decreasing and spacing antenatal visits, minimum 4 visits in pregnancy for those who are low risk at 12 weeks, 20 weeks, 28 weeks, and 36 weeks, unless there are complaints in between. We should be encouraged to utilize service of telemedicine for minor ailments in pregnancy. Those who are high risk continue to come for checkups more frequently as required by underlying condition. Healthcare workers. So far we know that there is no increased risk of acquiring infection in pregnancy. And pregnancy as such has no influence on worsening the course of disease. And there is no effect of virus on the fetal outcome mostly. With this background, those who have comorbidities have risk of worsening of disease. Comorbidities includes diabetes, bronchoasthma, HIV in pregnancy, heart disease, chronic liver disease, kidney disease, lung disease, blood dyscrasias, those who are on immunosuppressive drugs. These patients, when they acquire infection in pregnancy, are likely to have worsening of the disease. With this background, pregnant healthcare workers, in the absence of comorbidities and below 20 weeks gestation, are allowed to work in direct patient contact. But those who have comorbidities avoid working in hospital from any gestation. They are allowed to work from remote areas like telemedicine. Those who are working in patient areas below 28 weeks gestation, they should be following strict precautions to avoid acquiring infection. Coming to the major category of COVID, what kind of patients expect in future? Suspects, confirmed COVID cases, or recorded cases. We have 3 categories. Let us see first recorded category. They might have acquired infection early in pregnancy. They don't need anything other than TFA scan. Those who acquired infection late in pregnancy require close monitoring of fetal growth. Otherwise, it's treated the same as a non-COVID case in the rest of the pregnancy. Suspects, they may be symptomatic or asymptomatic. COVID case also may be symptomatic or asymptomatic. Asymptomatic cases are diagnosed only during triage or admission, antenatally or in labor. What are suspects and how to manage them? Those are symptoms of COVID like fever, sore throat, cough, muscle pains, headache are called suspects, symptomatic suspects. They may be mild suspects, moderate or severe suspects. Those have no symptoms but have history of contact with a confirmed positive case or history of travel also are called suspects. So what do we do those with the mild symptoms or those who have no symptoms? Both require quarantine. For how long? For 14 days. Where do we keep them? Hospital or home? Depending on presence or absence of comorbidities. Those who have no such complaints will stay at home and practice clinical self-monitoring. And those who have comorbidities require hospital quarantine for 14 days. Those who are at home, when should they contact us? When symptoms persist or worsen, they have to contact the respiratory clinic where they tested. Or if there are obstetric complaints, they have to contact the obstetric team where they tested. How do they contact? That inform that the suspect is coming to hospital for treatment. They can contact Corona Care Center in the hospital area. How do they arrive at the hospital? But by their own vehicle or the request for ambulance accompanied by minimum attendants. If patient is in labor, directly they go to the maternity block triage area. If they are not in labor, they have only respiratory complaints, they go to respiratory clinic and not to maternity ward. From the respiratory clinic, they are directed to triage area for patients where testing is done. The test done is Trunat test. It's highly sensitive and report takes 1.5 hours to get. Meanwhile, which patient requires admission among the suspects? Those having moderate symptoms or severe symptoms, or mother having comorbidities like diabetes, hypertension, chronic illness. They require admission if they have symptoms of severity or mild also. They will stay in the respiratory inpatient block till they get the report. Once report arrives as positive, they shifted to isolation ward or ICU depending on the need. They require multidisciplinary medical management and they require trauma prophylaxis also in your pregnancy, being high risk for thrombosis. Those who have mild symptoms and turn out to be positive with Trunat and have no comorbidities, they may be advised to stay at home, same as the patients of asymptomatic suspects. They also stay at home because the symptoms are mild and have no comorbidities. They remain stay at home quarantine. Those who came to maternity block with labor pains, they are tested for infection in triage area. Suppose their emergency condition, they don't have time for getting report. The returns positive case only to avoid delaying getting the obstetric care. Suspects not in labor or early in labor, give us time to collect the report. We will confirm them as positive or negative. Suppose they are positive or not in labor, how do you manage them? The confirmed case of positive case, not in labor, how to manage the patient later on. Here also, we have 3 categories. COVID mild symptoms, moderate symptoms, and severe symptoms. Those with mild symptoms behave same way as suspects without symptoms. They can stay at home safely and they should not come for routine checkups. For how long? For 2 weeks. If they have complaints, they can contact over the telemedicine. But if they have a severe complaint or emergency, they can rush to the hospital by ambulance with prior information to the hospital. Suppose they go on preterm labor during quarantine period. What do? Can we localize them? Can we give steroids? They can be given because patient's mild case, they are contraindicated in severe cases, and those with lung involvement should not give tocolysis or steroids. What do we do with patients at term gestation in quarantine? Postpone delivery plans unless there is a medical obstetric emergency requiring till report is negative in confirmed cases or till quarantine period is over in asymptomatic patients, suspects. On 2 weeks of quarantine, what do? They come for checkups where they are evaluated clinically, investigated depending on the gestation age. They may require growth scan and Doppler study if indicated. And if the preterm within 34 weeks gestation, you may consider administration of steroids. And if a term pregnancy, explain them about DFMC. They require delivery, you can plan delivery if indicated. How to manage labor in COVID patients? It's a teamwork. We have again 4 categories here. Suspects have no symptoms, mild COVID cases who are staying at home, that inform us before they're coming in labor. Because they're at home, that inform before coming to hospital. Moderate case and severe case already in hospital isolation area or ICU depending on the need. Suspects when they come to hospital, they have to go triage area for testing. If they're not in emergency, they have only early labor, you can confirm status there. Suppose they are in emergency condition, that to come to COVID block directly, where they receive the isolation room with lesser number of attendants and less staff also in isolation room. They should be wearing PPE of required need. Stage type 1 PPD is used in wards, in labor ward. You identify and train COVID response team who come in scene when we declare code blue in hospital. Like patient has emergency like TPH or patient has goes in shock or arrest, they have to come into the scene. They're called COVID response team, trained and ready to come to scene. How do you plan delivery? Is it vaginal delivery or cesarean section? Cesarean is reserved those have obstetric indication like CPD or in critical ill mother to relieve extra metabolic and pulmonary load. In these cases, weigh the risk and benefit ratio. Explain them the risk of losing patient in case you go for surgery. What is choice of anesthesia or cesarean section? Final regional anesthesia or GA. Both have no contraindications, but GA is avoided because it's a aerosol generating procedure. But it's the indicated anesthesia, recommended anesthesia for cases for pulmonary compromise. They should go for GA only in pulmonary compromised patients. How to give care to patient when she is in labor, going through the process of normal vaginal delivery? How to care for them? Mother, same as routine. In addition, monitor oxygen saturation of mother every hour. Keep it above 94%. And there is no contraindication to ARM in these cases. And try to avoid prolonged labor in these patients. How to monitor fetus? Guidelines recommend continuous fetal monitoring with CTG, but individualize the case depending on maternal condition and fetal gestation age. The mother is moderate severe case, the fetal bradycardia. There is no CPD. We don't plan section such cases. So depending on the medical condition and gestation age, individualize fetal monitoring in labor. How to care for baby at birth? Delayed cord clamping and call for individuals to attend baby at birth. What do you do in postnatal period? It's mainly infection prevention measure. Advise mother about breastfeeding, hand hygiene, respiratory hygiene, and maintain social distance after feeding baby. How to care for the caregivers? Advise them about rational use of PPE. Level 1 in wards, level 2 for current delivery because stage 2 of labor is a high risk condition. Level 3 for perform cesarean sections. Take home message. Apply infection prevention measures universally in all areas. Test all patients before plant or admission in containment zones. Test symptomatic patients in non-containment zones. Encourage wearing surgical masks for all asymptomatic patients and healthcare workers and maintain social distance. Thank you.
Yeah, thank you, Srilata. So excellent presentation from your own experience from your hospital. So I think all the people who are attending and watching this from YouTube video streaming and also through this webinar. So I think that so you're all witnessed with this live session. And also I request you have any doubts, please put the questions in chat box, so then we will discuss. And also we are having another hospital, so where they did this COVID positive delivery at Ashram Hospital. So I request Dr. Vandana to share what is the experience of the COVID positive delivery, how they did it, a quick review. So it's over to Dr. Vandana. Yeah, please go ahead. Yeah, go ahead.
Very good morning to all of you.
Yeah,
I think
yeah.
Dr. Srilata needs to leave the screen, only then I can.
Yeah.
It says I cannot start my screen share until the other
Yeah, yeah.
participant.
Srilata garu, మీ స్క్రీన్ రిమూవ్ చేసేయండి.
Anyway, I think at the onset, I need to congratulate Dr. Srilata for that wonderful presentation. It was so clear and explicit that I don't need to say anything about the guidelines. absolutely perfect instructions on the guidelines. And I would just like to share my experience with my team that we had recently. Dr. Srilata, I think you need to remove that. Yeah.
Yeah.
Yeah,
Sit down.
fine.
Yeah.
So, warm welcome to all the panelists as well as all those who are viewing this. And as we share our experience that we had at Ashram College a few days back. So the patient profile.
Doesn't matter. Carry on, ma'am.
So the patient profile that we had was a second gravida, paravan live one with a post-cesarean pregnancy at 36 plus weeks of gestation, who was absolutely asymptomatic. And she was diagnosed on routine screening with a TrueNat at the government hospital as a part of the routine protocol. And since ours was a designated COVID hospital, she was referred to us. And once she came to us, we followed the routine principles of antenatal care with the basic baseline investigations. And we isolated the patient and we were monitoring her by advising her to have a daily fetal movement count chart. And also we used our electronic fetal monitors. Then we gave her the routine supplements with routine like any other patient with iron, calcium, proteins, and multivitamins. And she was given a chloroquine based on the protocol that our hospital was following. And we were waiting for preparation and anticipation, and we had to buy time for the patient to reach her term. So in the meanwhile, we made sure our OT was totally prepared, and we made those changes which were hitherto not there, because as long as we were doing previously, there were different or rather common entry exit points, and we wanted to isolate these things. So now we had very streamlined the entry and exit for the patients as well as for the doctors. We defined particular areas for donning and doffing and made sure that there were flexis with the donning protocols to guide everyone, because it was a new thing and we did not want to miss any of the steps. We also made sure the small things like having a mirror in that room for doffing, and also a leg operated sanitizer so that we can minimize people who can assist us. Then we had dustbins which are properly labeled and kept separate so that when the healthcare workers were doffing, we could have that. And also we made sure that not only the routine instruments, but we also had extra instruments kept ready so that we would not be in a hurry at the time of emergency. Also, we made sure that we were not going to use electrocautery, and so there were enough instruments to take care of any bleeding. And since we were aware that we could not use our air conditioners, so we were anticipating that there would be plenty of heat, perspiration, and humidity, and we also made sure that we had our exhaust fans. So the OT setup was absolutely streamlined and kept in ready for any day for any emergency. We made sure the sister who was going to assist us in the team was thoroughly trained and we had a very strict way the instruments were laid down, and so that our surgeons would be finding it easy to use them. Also, most importantly, it was the preparation of the manpower. Not only the patient, but the doctor both had to be prepared. The patient was, of course, extremely anxious because the moment she was diagnosed positive, she was taken and put in our hospital alone without any attendant, and that made her very, very anxious. In fact, when she came, her pulse rate was at about 140, and we were worried if she was going in for a scar dehiscence. And it was only after a lot of counseling and continuously talking to her. In fact, our staff were talking to her 3 times a day. She had a phone with her, and our people were continuously talking to her, assuring her that she would be all right and we are there to take care of any emergency. It made a huge difference. That counseling made a lot of difference. And finally, we found that her pulse rate was coming down. Initially, we were actually worried what the cause was. What also was very important was the preparation of the doctors, because however much we know about the COVID data and whatever the information, everyday guidelines, the PPs, everything, it is all coming to one side when you have to really step into the OT and do it yourself. So both the patient and doctor, I think, went through different phases of shock, first fear, anxiety, and then slowly they were able to accept, and finally the preparedness for both the patient and the doctor, which was very, very important for us. So we kept the fixed teams in readiness so that we knew who the team is going to handle the patient anytime that the patient needs an emergency or as an elective procedure. And we kept repeating the drills. So as if the patient was going to be there, and how we would do all the steps with the entire staff. It was not just important that we were ready. We wanted the anesthetist, the pediatrician, the nurse would come with us, the OT technician, the sanitary worker who was going to help us clean the whole place. Everybody needed to be told how to don, how to doff, and what route they should come, so that there would be least possibility of contamination and infection. So the protocols were absolutely fixed, pre-op orders, post-op orders, everything was pre-planned and kept in readiness. Very importantly, we made a consent and counseling very clear to the patient and the attendant so that they would be prepared for any kind of outcome. And that made it much easier for our doctors also. The preparation for any emergency was absolutely done to the every detail possible. Our PPE kits were procured and kept in readiness, and a little few extra were also there. We were aware that once we had the PPE on, it would be very difficult to hear anything with so many layers on. So we had to make sure that there were some bells and some codes so that the people would understand what the surgeon was trying to say. For the simple reason, if they find that there was some difficulty during surgery and they wanted another senior gynecologist to come in, we would ask them to ring one bell. Or if they wanted a surgeon in case of adhesions or a bladder injury, we had 3 bells or something. They had all codes for everything. And also we realized that there would be a decreased tactile sensation. So these things were in preparation so that the surgeons who were operating were already mentally prepared. And what all are the emergencies that they could anticipate? Any excessive uncontrolled hemorrhage, any adhesions because it was a previous cesarean, any possibility of bladder or bowel injuries. All these things were kept in mind, and we made sure that all the suture materials, drugs, blood, everything was in readiness. We also made sure that there was, as I said, an extra gynecologist and a surgeon in the waiting, and also all communication protocols between staff were standardized so that they would really understand what each of them were trying to tell the others. Very simply, we had made this communication for ourselves very simple by showing one finger, 2 fingers, 3 or so for all the oxytocics, and it was pasted on the wall so that everybody would understand when the surgeon would show one finger, they wanted 5 units of oxytocin and so on. And similarly, also the bells, as I said, were also put up, and a remote calling bell was installed so that they could call the person inside if required. So the codes for the anesthesia team also they were following the standard codes. And in case the patient needed general anesthesia, we made sure that the hood was kept ready so that they would minimize the aerosol spray. Then also the neonatal corner was kept ready at more than 2 meters away from the OTs, outside the OT, but within the complex. And the pediatrician was also available with all the PPEs and everything in readiness. So once all this was going on, we were waiting in case there would be an emergency. However, after waiting for 10 days, when the patient was also comfortable and a repeat scan showed a 3.5 kg baby, and even then the patient was complaining of pain, and we were worrying if they were going for scar tenderness or dehiscence. Then finally, when we were thinking that there was a decrease in the viral load, we decided to do an elective procedure. And once the elective procedure was planned, we decided to go in a phased entry into the OT. The anesthetist would enter and keep everything ready for anesthesia. And once the spinal was almost ready, then the obstetrician would enter. And once the obstetrician was ready, they would ring the bell for the pediatrician to enter. So that once this phased entry would decrease the exposure of the healthcare workers to the patient. So we were trying to minimize every chance of exposure. Also, we made sure that the minimum staff were entering the OT and maximum speed at surgery. Of course, with minimum interference, when we have too many people assisting, quite often we find there's too much interference. So everything was pre-planned, even the way the instruments were going to be, the order, everything, so that there would be no confusion. And also decided for a subcuticular closure with Vicryl so that we could avoid a suture removal further later in the postnatal period. So in the postnatal period, as the baby was a lovely 3.4 kg male child, and baby was absolutely fine. So routine postnatal and neonatal care was given as per the guidelines, as was discussed by Dr. Srilata. The baby tested negative, and initially the baby was artificial feeds when the mother was not able to get the milk. And once the milk was established, we are now giving the baby the express breast milk. Now it's post-operative day 6, and both the mother and baby are doing absolutely fine. And we are waiting to see that the mother report comes negative so that we can room in the baby with the mother. And I want to say that ultimately what mattered was the team effort. The anesthetist, the pediatrician, the nurse, the OT technician, everybody, including the sanitary worker, all of them played an equal role in making this successful. And I would like to say that it really mattered. So many things came into our mind when we were planning, and these things, I think, for the next case, we are more prepared. And at this juncture, I want to say a special thank you to my team, Dr. Anjani and Geetika, and everyone in the OBGY family who supported and made this possible. Thank you.
Yeah, thank you, ma'am. So your experience is excellent, and you have followed all the protocols. So it's nice to hear. So I think that so all who are participating from all the medical colleges and the hospitals, so they are watching your live experience. So what had. So I hope that so all other hospitals also should follow these all protocols very strictly to avoid the exposure to ourselves, and also to the baby care is very important one. And I think that there is somebody, Dr. Chandrika is there from Rajahmundry. They also did the one delivery. So Nagendra, can we pick up? So you are getting the name of that, Dr. Chandrika. Dr. Chandrika, are you able to hear?
No, sir, there is no name as such, Dr. Chandrika.
Yeah, okay. Then we will move to the, okay. Thank you, ma'am. So excellent presentation from your side, and anyhow, Srilata done excellent job. Their positivity rate was very much fairness to all the state, but the way they prepared the triage area and all those things is one of the most beautiful ways they are presented, and they prepared also. I think that so that is one of the most interesting one, and everybody should follow that, how they prepared for the from the triage to the postnatal care. So from the Karnool Medical College. Now I think that now the baby is delivered, so baby is happy. So now we have to see that what's about the newborn baby care. So now I invited Dr. Rama Rao from Andhra Hospital. So he is a pediatrician. So he'll tell that. So what is the baby care? So we want to give. Dr. Rama Rao. Rama Rao is here. Is able to hear. Yeah. Please go ahead. Yeah, he is about to share the screen, so he is online. Yeah, Dr. Srilata. So in between, so we will go that you did all the who are attended the this delivery and all those period. So I hope that so you are all underwent testing after some period. So everybody is negative.
Yes, sir.
Negative. You are muted, so you can speak. Unmute.
Yes, sir. All tested negative for the disease, sir.
Yeah, a little bit loud. I want that one.
They're all negative, sir. After delivery, also delivery, they're negative, sir.
Exactly. So I think that so I want to share this one to all of you that they did more the 3 deliveries, 1 section and 2 deliveries, and all the healthcare fraternity is negative. So don't afraid of anything. Just take the proper precautions. So that's want to highlight from this point that so they did all the even the section also they did, but nobody is infected, and all the healthcare fraternities from the staff nurse to the doctor and the OT specialist anesthetist, everybody is negative. So it's one of the most important one, and boosting one to the all the other people so who are working at gynecology obstetrician areas. And what's about Dr. Chandrika gar, Dr. Vandana garu? You're also no? You did all the tests for all your
So
staff and
we're due for
yourself.
the test. Yes, sir. We are due for the test tomorrow, and we hope that they will be negative.
Yeah. You are acha, till waiting for the
Yes,
reports.
yes, yes.
Yeah, okay.
It just happened recently.
Yeah, nice. So Baby or both the babies are doing very well.
Baby
No?
is tested negative, sir. Our baby just came
Yeah.
negative.
Srilata garu, all the 3 babies are doing well. Yeah, there is no problem. Okay. Is there any problem with the Dr. Ramarao? So, Ramarao garu, can you just start? Okay, at least orally you can say that. What is the baby care so you can take? If any problem with the screen sharing,
Yeah.
Rambabu sir, in the meantime, can we have questions with respect to
Can you see?
COVID-19 and pregnancy?
Sorry for that. Yeah, can you see this slide now?
yeah.
Can you hear me now?
Yeah. Loud and clear. Carry
Yeah.
on.
Okay, so that's clear. No, sorry for that. Sorry for the interruption. First of all, thanks to Department of Health and Government of AP, the UNICEF,
నేను చేస్తాను.
Dr. Rambab Garu, and all other doctors and nodal officers. Hello?
Yeah, carry on.
Yeah, can you see my slide?
Yeah. No.
No,
Yeah.
I'll share from my side. Can you just ask Nagendra Garu to stop?
Yeah, he is doing.
No, I share it from my side, Dr. Rambab Garu.
Dr. Ramarao, we can't able to see the slide, so I'm trying to share from my side.
Oh,
Is that
it?
okay?
Yeah, that's fine. You have amended one, now you have the new one.
The one which you have forwarded, I mean, Dr.
Recently, just I think 1 hour back. Did you have that presentation? I forwarded it around 10:30 or so.
Well, no, it may not be there with him, so I didn't forward it to him.
I'll share it from my side. I think it's just if you could just hold on to me just for a minute. I'm sorry for that. Just give me a second. In the meantime, we could go for a question and answers, Dr. Rambab Garu.
Yeah. Nagendra, what are the questions? So
Yeah.
See this slide now.
So there are a couple of questions for Srilata ma'am and the other panelists we have.
Vandana.
Nagendra Garu, can you see the slide now?
No.
No. You need to open the PPT first and then please share the screen. Okay, so can we have questions?
Yeah, please.
Yeah. So the first question is, what impact may an unborn child have if the pregnant mother is COVID-19 patient? Dr. Srilata ma'am, please.
No significant effect on fetus unless the mother goes into preterm labor. No effect on fetus.
Thank you. So can you please repeat that a little bit louder, please?
There is no effect on fetal outcome in pregnancy. Mother is infected with COVID-19.
Yeah. So there is no significant effect as such on the baby when a pregnant mother is COVID-19 positive.
Yes.
Okay. So the next question is, when do we test in ANC? 15 days before EDD or during entire gestational period once?
5 days before EDD or when she comes in labor.
Thank you, ma'am. It's 5 days before the EDD or when they have admitted for the labor. And the next question is it necessary to switch off ACs during cesarean section?
I have no idea, sir.
Yes, sir. They did say that it is safer to switch off the air conditioners. and because it causes more chance of the infection. So we did try to follow that protocol, but it was extremely suffocating, and I think it is very uncomfortable, but I guess that is the best thing to do. And we also had some exhaust put up.
Thank you, Dr. Vandana, for that. Yes, some of the literature is also saying if the AC are advanced and having the first start, then we can the ACs are good. So that is what the existing is saying. And the last question is, what about the role of HEPA filters OT?
Nagendra,
Yes.
your question is not clear. There is speaking.
Okay.
Well, so we will ask the Dr. Ramarao to continue this one.
Yeah, you could see my slide.
Yeah, please.
Yeah.
I think the screen is visible now.
Visible? Is it visible
Go
now?
ahead.
Yeah. Carry on. Next slide.
Yes, it is very much.
I'm audible, and also screen is slide is visible. No?
Yeah.
Okay. Thank you. Now, thanks to all, in particular, Dr. Rambab Garu, and thanks to Department of Health and UNICEF. I know that you're all working very hard. All the doctors, nurses, they're working around the clock. All frontline people and the expert critical care panel, all senior health officials and health secretaries, and everybody were working around the clock. In the last 3 months or so. Coming back to my topic is on care of a newborn. So my topic is very simple. It takes only about 15 minutes time or so. So obstetricians, please don't go away. I'll try to keep it very short. So what you do, once the baby is delivered, this baby is born to mother with suspected or confirmed COVID-19 positive. Recently, so the couple of babies delivered in Kannur and one in Ashram. So like that in different places in Telangana, and a few deliveries in Telangana, a few newborn babies, and also North India in Indore, Delhi, Ahmedabad, in different places. And children also, there are quite a few people infected recently. Few in Andhra Pradesh, about 80 plus or so in Telangana, children, not newborns, and a few children in Tamil Nadu. I think more than 120 people got infected with the corona in Tamil Nadu, and few in different places in North India. As far as newborns are concerned, there are few corona positive newborns in India. One in, I think, in Indore, and also in Delhi. And one neonatal death, not exactly neonatal death. I think that a 6 weeks old baby died recently in Delhi. So if you take it globally, there are a few some newborn corona positives, and very few deaths, globally. But having said that, you need to be careful. You can't take any chances. So as Dr. Sirisha and Dr. Vandana discussed in detail about the delivery and antenatal care delivery, and then so what happens next and all. So I'm going to concentrate on just only on newborn care. So let's say that the baby is delivered to a mother with COVID-19 positive. So what to do? Obstetric team, we already discussed. They should wear PPE. That's must. So there are only 3 things actually. In COVID-19 positive cases. One is taking precautions. All healthcare staff should take precautions. That means wearing PPE and all. That is number 1. Number 2 is isolation, and in number 3 is supportive treatment. Number 4 is basically team management. We talk any child or any adult or any patient with COVID-19 positive one. These are the 4 things only. You take care of yourself, healthcare staff. That's number 1. Number 2 is isolation. Number 3 is supportive treatment, and then number 4 is basically team management. That's what we are talking about. The management, in the last 3 months or so. So what you do? So object team, wear PPE. That's mask. That's already been discussed. And then delivery mode is usually dictated by obstetric team, and it's basically depending on the indications that they will decide whether mother will go for normal delivery or cesarean section. And of course, neonatal team, whoever is attending delivery, they should wear PPE. All doctors and nurses, they should wear PPE. That includes, of course, eye shield and N95 mask. So once the baby is delivered, now what you do? Deliver to mother with the COVID-19 positive. So what you do, whether we need separation or not, I think it's better to consider temporarily separating baby. Next one. Temporarily separating baby from mother if possible. So initial separation, what you could do is you could keep the baby in the neonatal unit. If you have neonatal unit, you keep the baby in the neonatal unit in isolation. If you have isolation facility in the neonatal unit, you could keep the baby over there. Or if not, you could keep the baby in the postnatal ward of the ideally in the separate room. So then comes milk. We need to start babies feeding within half an hour of delivery. So what you do? So whether to give direct breastfeeding, or whether to give express breast milk, or whether to consider formula feed in this specific scenario. So ideally breastfeeding, and you all know that breastfeeding is best for the babies. But in this particular scenario, it is better to consider expressed breast milk. So once the mom comes out of anesthesia, you could ask the mom to express milk, if she can. So that in an ideal situation. So suppose if mother and baby are not separated, and if mom wants to breastfeed, what you do? So mom could breastfeed, but only thing is mother needs to take all precautions. That means wearing masks, ideally three-layer surgical mask or N95 mask, and then washing hands and before and after handling baby is very important. And then gloves as well, if available. So you could breastfeed the baby, but your mother has to take all these precautions before mom feed the baby. Then so what you do about the isolation? So as I said, that initial separation, keep the baby in isolation if you have isolation facility, and then till we get these results from mother, and also results results from the baby. Regarding testing for newborn babies, so once you suspected COVID-19 in mothers, or confirm the case of COVID-19 positive mother, we need to do testing in newborn babies, ideally within 24 hours, and we will also repeat the test after 48 hours. So two times we do testing twice in newborn babies. Regarding the presentation, so majority of the babies are asymptomatic, as you already know, but some could present with the mild symptoms, but most of the babies recover without complications. So they do present with the non-specific symptoms. For example, babies could present with temperature instability. You don't get fevers that are often in newborn babies. So usually they could present with hypothermia or with fever, and they also have other symptoms like cough, difficulty in breathing, that means respiratory distress, tachypnea, sometimes it's diarrhea, poor feeding, lethargy, feed intolerance, and all those things. Now, all those symptoms will be there in the sepsis as well. So it is very difficult to differentiate whether you're dealing with the COVID-19 positive baby or the baby with an neonatal sepsis, or with the baby with the other respiratory conditions. For example, in preterm babies, preterm babies with respiratory distress, each could be hyaline membrane disease as well. In term babies, it could be transient tachypnea of the newborn, or it could be congenital pneumonia, or it could be meconium aspiration syndrome if there is a history of meconium aspiration. So it is very difficult to differentiate. Usually it presents with non-specific symptoms. So of course, you take detailed history and do the detailed clinical examination. The usual mode of transmission in newborn babies is again respiratory droplets. So respiratory droplets from mother or other healthcare staff or other healthcare givers or visitors. So they could transmit the infection to babies. So regarding transmission from mothers to babies, there is no significant evidence. There is a lot of discussion what's going on, but there is no significant evidence to say that there is intrapartum or peripartum transmission. In that, vertical transmission from mother to baby. So there is limited evidence. It's not clear. So we could say that there is no significant evidence to say that vertical transmission at this point of time. Then what you do? So baby delivered to COVID-19 positive mother. So what you do? So as majority of the babies are asymptomatic, so all neonates born to mothers with confirmed or suspected COVID-19 should be very important, should be considered as having COVID-19 until the test results are available. So this is very important statement. So treat this baby is having COVID-19. And of course, you need to isolate these babies from other healthy neonates. If you want to keep the baby in the neonatal unit. I'm not going into the details about the neonatal intensive care management of COVID-19 positive babies. That's a completely different topic. So what you do about the separation? As I said that temporary separation may be needed. So you could keep in the same room where mother is staying in, because so as we know that the mothers and babies need that touch, that emotional bonding with the mother. And then kangaroo medical care for preterm babies, and then rooming in day and night. That's all needed for newborn babies. We don't want to separate these babies for a longer period of time. But in this particular situation, temporary separation might be needed. So when you're keeping the baby in the same room, you need to maintain the physical distance of at least 6 feet or so. And then ideally, so it's better to keep the baby in the incubator till you know the clinical status of the baby and also the mother. Then, then neonate is tested positive for COVID-19. Then what you do? And of course, mother is positive, baby is positive. You don't need to separate actually. So you could keep the baby with the mother. And then regarding the face mask, what you do, whether we need to keep the baby for neonates, no, it's not necessary. Don't do it. So no, could advise face mask only to the children above the age of 2 years. Just think about that and consider. And regarding discharge, what you do? Basically, discharge depends on the clinical condition of the baby. Depending on the test results, we will decide whether we could discharge the baby with the mother or not. Of course, this baby needs close outpatient follow-up. And then when you discharge these babies, so you need to tell the mother and other health caregivers to the warning signs. That means the baby develops any symptoms like fever or cough or any respiratory distress or diarrhea or poor feeding and lethargy. So they need to inform us. They need to come to the hospital to get the proper clinical assessment in the pediatric hospital. To the next slide, the potential for postnatal infection. So, of course, you need to take all precautions. That's what we've been discussing, and then follow all the guidelines for aerosol generating procedures. I think we did discuss this one so many times. Suppose if you want to intubate the baby in the delivery room or in the neonatal unit, you need to take all the precautions while intubating, while doing suction, while ventilating these babies. So if you want to put the baby on HFNC or a CPAP or ventilation, and you take all guidelines for these aerosol generating procedures, because of the potential risk to the healthcare staff. So of course, as I've already said several times, healthcare professionals should wear a PPE. And if the baby needs it is better to keep the baby in the incubator and do the things. Mute, please. Other doctors, please mute. So then come to feeding. Then what you do with the feeding? So as I've already said, breastfeeding is the best for the babies. So you need to see whether breastfeeding is better. You need to balance, but the benefits of breastfeeding versus risks. So I think benefits of breastfeeding currently outweigh the risks of passing infection to the baby. So you could carry on with the breastfeeding as long as you take precautions. So there is no evidence to say that coronavirus is secreted in breast milk and transmitted to the infant. There is no significant evidence to say that. So you could definitely breastfeed. And then mother-to-child transmission, as I've already discussed, is very unlikely. So there is a very limited data available to suggest this. So this is very unlikely. So if mother really insists on breastfeeding, again, I'm saying that mother should wear the protective gear that includes a mask and then washing hands and using gloves before and after breastfeeding. So, mothers have tested positive. I already told you, who have tested positive for COVID-19, and the healthy babies, they are tested positive. They don't need any separation. So next slide is, if you have COVID-19 positive mother and choose to breastfeed, what you do? So that is one is, of course, taking precautions using face mask and washing hands. I've already discussed, and then mother can continue to breastfeed. So you need to take 3 precautions. That is 3 W's. That's wearing a mask. First one. Second is washing hands. Very, very important. And then wiping and disinfecting all close contact surfaces. So is very, very important. And next one is, if a mother is COVID-19 positive and then mother choose to express breast milk, so you could, so the only thing is you need to use a clean cup and spoon and then express the breast milk and give it. Use a dedicated breast pump, of course, and use face mask and wash hands. Clean all the equipment before you express the breast milk. So you could consider expressed breast milk. If the mom is too sick to breastfeed, you could consider this one. And so what you could do is you could ask the other healthcare giver or grandmother or nurse or other person who is in that room who is comfortable to give the feeding. You could ask that healthcare giver to give the feeding to the baby if mother is too sick to breastfeed. Then if mother, let's say that mother decided not to breastfeed, or if mother is unable to breastfeed because of the moderate to severe symptoms, then of course, and as I've discussed, breastfeeding is the best for the babies. In this particular scenario, you could use the formula feeding, but you need to thoroughly wash the bodies and teats and other equipment before you give the formula feeding. So just to conclude, so wear PPE all the time, both obstetric and neonatal team. We did discuss so many times. Temporary separation might be needed. There is no contraindication to breastfeed in these babies. Express breast milk, that's preferable in the initial hours. And then, of course, breastfeeding after taking all precautions. So presentation in newborn, most of the times it would be asymptomatic, and some could present with mild symptoms, as I've already discussed. And transmission, usual mode of transmission is through respiratory droplets. There is no significant evidence to say this vertical transmission of secretion in breast milk, and isolate this baby from other highly needs. And of course, consider close outpatient follow-up for these babies, and tell about the warning signs. So take utmost precautions for aerosol generating procedures in NICU, as I've already discussed. And lastly, breastfeeding is the best for all babies. The alternative would be expressed breast milk with clean cup and spoon. So finally, I would like to end the discussion with only staying active and proactive will make you want to live 100 years. That's a Japanese proverb. Thank you one and all.
Yeah, thank you, Dr. Ramarao. So excellent presentation on newborn baby care. So we'll take the questions later. So now I request Dr. Sheila Deb, Deputy Commissioner Child Health. So I request to give the message. Dr. Sheila. Yeah, good morning, madam.
Hello, yes, I'm audible.
Yeah, you are audible, madam. Please.
Okay. So good afternoon, everyone. Thank you all for arranging this webinar on a very important issue. So I joined you and I was listening to you all, and I just at this point of time I found that very good presentations were made by Dr. Ram Babu, Dr. Vandana, and Dr. Ramarao. So I can have some comments at this point of time if I am allowed. So 2 or 3 points I want to highlight. As Dr. Bandana, I had also put that my comments in the chat box, that for the COVID positive mother also, as per our guidelines, GI guidelines, and also this is the same for UNICEF and WHO guidelines, that we recommend that the mother, even if COVID positive, mother should be isolated, and the baby should be with the mother only, and the baby should be breastfed if the baby is healthy. And breastfeeding should be done with due precautions, and Dr. Ramarao has already pointed out 3 things. One is that the hand hygiene has to be maintained by the mother, respiratory hygiene, that is putting masks, and then third is the cleaning of the surfaces, that has to be done diligently. So these 3 things have to be followed. And if the mother is sick for any other, if the mother is not being able to breastfeed, and the baby has to be isolated in that case, or if the mother is healthy but the baby is sick, in that case also the baby has to be isolated. But the baby should be kept separately, not with the other newborns. In the even in the NBSU or SNCU also, if the mother has to be shifted, the baby has to be shifted. In that case, the baby has to be kept isolated actually. But all efforts to be made to give the baby mother's own milk, express breast milk. And if that is not at all possible, we are going for the third option, that is the donor human milk, if possible. If if now, what I understand, in every facility, it will not be possible to provide donor human milk, but that is the next option after express breast milk. And then if none of this is possible, and then that case only we will be advising to give this formula feeding, because you all know that formula feeding actually suppresses mother's own breastfeeding process. So as early as possible, we have to resume the breastfeeding or express milk feeding. And the third thing I heard in the last presentation, Dr. Ramarao, you was mentioning about bottle washing, thorough washing of bottle. But we are always suggesting that bottle should never be used. You should use a cutlery and spoon and that thorough washing of those things have to be done. But bottle feeding is strictly, it is prohibited actually. Okay. So thank you all, and please continue, and I will be listening to you. If I have any comment, I will again join at the later time, or I can put it in the chat box also. Thank you, Dr. Sanjeev, and thank you, Salima, also. Thank you all.
Yeah. Thank you, ma'am. So now I request Dr. Geeta Prasadne, Additional Director, Maternal and Child Health. So can you share your views, ma'am? Dr. Geeta Prasad. Yeah, are you able to hear, ma'am?
Yes, sir.
Yeah, please go ahead, ma'am. Yeah.
Sir, I want to
No,
strengthen my family.
something wrong with your speaker. Something wrong with your speaker? No, no, no. Your speaker is not fine. No. There is some problem with your speaker, ma'am. Now we try again.
Are you able to hear me, sir?
No, 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 no. There is some problem with your speaker. It's a breaking and a resound is also.
Yes, sir.
Nagendra? No, no, it's not coming, ma'am. It's not clear. So Nagendra,
Yes, sir. Please tell.
Sanjeev is ready. In the meanwhile,
yeah.
check that what happened to the ma'am. Okay.
Yes, yes, yes.
So now I request Dr. Sanjeev, so well known to all of us, and is the health specialist in UNICEF and helping the state government for conducting most of the training sessions. And I request now Dr. Sanjeev to give his message. Dr. Sanjeev.
Thanks, Dr. Thanks, Dr. Ram Babu. Am I audible?
Yes, yes, loud and clear.
Fantastic. So, let me thank Dr. Ramarao, all the presenters from Kurnool Medical College,
Ashram Medical College.
from Ashram Medical College, and our Andhra Hospital, Dr. Ramarao, as well as all the participants. This is just 4 minutes to 1, and I know that at most of the hospitals, most of the people, they break for lunch at 1. So I'll not take long. I just would like to thank first, apart from all the presenters, also Dr. Sheila Dev, the Additional Director, Additional Commissioner Child Health at the Ministry of Health, Government of India, who could spare some time and participate in our Zoom session. Thank you very much, Dr. Sheila. And colleagues, I just would like to say that we did a lot of webinars so far since we are in this pandemic, and when physical or face-to-face trainings have become difficult, we are hosting these trainings or different technology platforms with the help of state government, especially Dr. Ram Babu and also Dr. Geeta Prasadni. We actually were able to host not less than 35 sessions so far, and at least 10 of those were on hardcore technical issues. They are difficult times, all of us are aware of it. While COVID remains the top priority of each one of us, continuing RMNCH services are equally important. Of late, we have a lot of news from the media where we see that women, they don't get a hospital for institutional delivery. Someone delivers on road or en route to a health facility. Some people are denied to get admission in hospital on account of COVID. So many such news are coming. And now there are very clear-cut guidelines from the Ministry of Health and Family Welfare, Government of India, as well as state governments, that we should not stop continuing our ongoing services on reproductive, maternal health, newborn and child health. So those we need to continue. There are guidelines for each and everything, and none of these guidelines stop us from continuing our routine services. And you heard from all speakers today, everyone said that with little precautions we can continue our services. These are testing times for us. It's a bit difficult to get some of these protective gears in the beginning, but with time we are able to get these PPEs and other things, and we are able to also make people aware how to use them. So my request to all of you to continue our routine services with needed precautions as mandated by state government and Government of India. So I wish you good luck, and I always say that this is just one of many programs, and with time we will come more specific programs. You can reach out to Dr. Geeta Prasadni, Additional Director, or Dr. Ram Babu about your specific requirements, and we will see that we have some of the best resource persons, those who work on academic side as well as those who work on program side, to bring those guidelines, their experiences for you, so that you can continue services as usual. So thanks one of all, and I wish you good luck, and hopefully with this experience, what we learned from these two medical schools, specifically the way they treated their patients during COVID times, it's really commendable, and we have a lot to learn from them. So thank you, and I wish you good luck again.
Yeah, thank you, Dr. Sanjeev. So excellent message from you. I think so you are doing a great help to us while conducting this training sessions, and your boys are so excellent. So whenever we call, so they are helping us. Thank you, Dr. Sanjeev. And now I request Dr. Geeta Madam is ready. So we will take a last final call, whether she is ready or speaker is okay. Dr. Geeta Prasadni, Additional Director, Child Health. Madam? Yeah, Nagendra, so if Madam is not ready, so shall we go to the question and answer session?
Are you able to hear?
There is a problem with your speaker, Madam. Voice is cutting and resounding. Some problem. Nagendra?
Yes, sir. We can go ahead with the questions.
Question and answer. Yeah. Let us go for the quick review. Yeah, go ahead.
So do you want me to ask?
Yeah, start.
Okay. So one of the questions is it recommended to give chloroquine tablets to antenatal mother before or after delivery?
Positive? Or just like that, prophylaxis?
Is it recommended? Yeah. It seems they're asking for a prophylaxis.
So, as such is prophylaxis for the pregnant mothers, so we are not giving. So, no need to go for that.
Yeah. And the zero-dose vaccination can be done to COVID-19 positive newborns. Can this be done?
What is that?
Zero-dose vaccination can be done to COVID-19 positive newborns or not?
Yeah, Dr. Ramara, are you able to hear?
Yes, sir. So if the baby is positive for COVID-19, There is no reason to wait for the vaccination. Normally, BCG, polio, the OPV, and the hepatitis B vaccination will give it within 24 hours. We're not supposed to delay the vaccination. I would say that we need to go with the vaccination, or maximum with the child. If the baby is too sick, let's say that COVID-19 positive baby admitted to the neonatal intensive care unit, so needing all supportive treatment, including ventilation and all. In those babies, you could delay up to 2 weeks, but not more than that. So the answer to your question is the vaccination. Yes, no, go ahead. So now if the baby is too sick, no, you could wait, up to 2 weeks.
Yeah. Okay. Thank you. Now the next one.
Thank you so much. The last question is, what about during gestation? Can the COVID positive mother be infection can transmit from mother to baby during the gestation?
During the gestation.
Yes.
Yeah. Anybody?
So far, there's no evidence, sir.
Yeah.
No evidence so far. No evidence so far, sir. No
Yeah.
evidence
Till now, there is no evidence of the vertical transmission, not yet. So no need to worry. Next one.
Thank you. So our participant wants to know whether voluntary testing is available, especially with respect to pregnant women.
Pregnant woman?
Voluntary testing.
At any time? At any given
time? Yes, yes.
So we usually, so if they asymptomatic and they are anyhow staying in the home only, if there is no contact is there, they are not from the containment zone or the red zone is there, nobody is affected in the family and nobody is in a traveling area or any history is not there. So as a routine case, so I don't think so that there is any need of testing to the routine testing for that. But as such any, typically in the containment zones or otherwise somebody has traveled and entered into the home or otherwise anybody is in the symptomatic, those persons needed the testing of it. Otherwise, regularly asymptomatic and who are staying in the home, other families are also healthy. So I don't think so that there is no need of any voluntary.
Okay.
Thank you so much. And one last question is about, are corticosteroids indicated in high-risk COVID with anticipating preterm delivery?
Not in severe cases, sir. Only in mild cases you can administer corticosteroids.
Mild
And suspects, but not in moderate and severe cases.
Moderate to severe cases, so you are not giving.
Not giving.
So you are given for the mild cases methylprednisolone given.
Betamethasone, sir. Betamethasone.
Methylprednisolone.
Betamethasone.
Betamethasone, so you are given. Already given to anybody?
No, sir. We can give in case of need.
Yeah. So, Tamara, so can you throw light on the steroid role in pregnancy? Any role is there? So as a routine cases, so what we are treating with the steroids, or so as such is the pregnancy or the any contraindication steroids?
I don't think there is any.
I don't think so. That
I don't think there is any contraindication to use any steroids, antenatally. That really helps. As all the obstetricians know that. So as per obstetric indications, the mom needs and steroids, I think we could go ahead. I don't think there is any significant evidence to say that just to stop steroids in mothers with severe cases. And I'm not aware of that. I think the obstetricians would answer this question.
I think the FOXI guidelines are very clear on that we can go ahead with steroids. There is no problem. Between 24 to 34 weeks, you can actually give steroids, no contraindication. The FOXI guidelines are very clear.
Yeah, I think that's very clear.
That's very clear. Yes, there is no contraindications of the steroids as a routine case also. So, and when you are anticipating COVID will cause the cytokine storm and complications are there, so safely, so you can go through this one. So no need to worry about this one. So because there is nothing, any literature has shown that steroids are contraindicated in pregnancy. Nagendra, is it clear?
Thank you. Thank you so much. So
Yeah.
now at this point of time, Dr. Sheila, they want to come in, to mention with respect to immunization.
Yeah.
Dr. Sheila, ma'am, please.
Yes, I have now, just now I heard about that question that on immunization of the newborn, if the newborn is COVID positive. So I have now confirmed with the immunization division, Dr. Haldar, and it has been told that it can be done. There is no contraindication for zero dose immunization in newborn if the newborn is COVID positive. Okay.
Okay.
That's
Okay.
my.
Thank you, ma'am.
Thank you so much.
You're welcome.
So,
Nagendra, any more?
Rambab Garu.
Yeah.
Ramokar, it's a very quick question, Andy. So regarding, suppose if mother wants to go for testing for COVID-19, so now our government had given accreditation to the private labs. So suppose if mother get in touch with us that saying that she wants to go for testing, can we recommend to the private lab to go for testing, Rambab Garu?
As such, so for the asymptomatic cases also voluntary testing we are encouraging. So each district, so we are choosing that asymptomatic cases, so they can directly go and check that just I am having the doubt and they can go for and test this. So there is nobody is going to obstruct you that so why you came here. So now, so out of the districts, if the 4-5 centers are there, so one center will be labeled as a asymptomatic cases. So you can go. There is no need of any travel history. There is no need of any symptoms are needed, and we are encouraging the voluntary testing. So naturally, whether it is pregnant or diseased or whatever it may be, so they are comes under that category. They can go directly for the voluntary testing in government setup only. No need of the private labs.
Thank you.
Yeah. Nagendra, is it?
yeah, so I think we have taken almost all the questions, and also Dr. Srilata ma'am and Dr. Vandana ma'am has already responded to many questions. So I think we can close here now.
Yeah. Thank you very much. So all the speakers and Dr. Srilata, so you did a wonderful job. So Dr. Ram Prasad sir told that so you are going to do well, and you are come to the expectations also. So nice. So Dr. Vandana ma'am, so with a very short duration of time, so I'm seeing that you are so enthusiastic to participate in this one and to share your views. So excellent. And of course, Dr. Ramar, so we are very close because we are always moving together more than 3 months. so sharing our views. And particularly Dr. Sheila ma'am and the Dr. Gita Prasadni. And most important person is that Dr. Sanjeev, so is helping to conduct these training sessions. And particularly Dr. Nagendra and Dr. Anil and Uma Shankar. So your team is excellent, Dr. Sanjeev. So all the people are helping because particularly we cannot go for the face-to-face or the live sessions with all the colleges. So we did all the training sessions from January onwards itself only. But from that onwards, once such a busy schedules and also there is a changing of the guidelines, protocols every time. So we have to learn so many things regarding this COVID. So we started this training sessions. There is a huge response for today's session. It's more than 250 logins from this laptop only, and more than so many logins from the YouTube streaming also. Live streaming is going on. So really very happy. So everybody is participated. I think that they shared the wisdom of all your views and live views. So that is very important one. So we selected the Kurnool because they did the 3 deliveries. It's not the theoretical one. Somebody is speaking, so we don't want that. So how they did, and the ashram is also did the 1 delivery. So that's why we selected those colleges to share their views. And thank you very much, everybody, for participating this. And I think that this session is ended now, so we can go further. So thank you, Nagendra. So we are closing this session now. Thank you.
Thank you. Thank you so much, sir. We are ending the meeting now.
Yeah. Thank you.